Good morning, everyone. Welcome to Grand Rounds. We have a special lecture today, Skolnick, in honor of the Skolnick family. And with that, I'll turn it over to Dr. Berkins, who will introduce our speaker.
Hey, good morning, everyone. My name is Franz, and I'm one of the new internal medicine chief residents. And I'm very excited to introduce this year's Ellen Susan Bromberg Skolnick Lectureship for Humanism in Medicine. This award is given annually to a clinician who demonstrates exceptional humanism as a part of their regular practice. Ellen Susan was an exemplar humanitarian who volunteered her time educating physicians to see patients as the people they are. She knew firsthand the importance of not only clinical excellence, but also compassion, respect, integrity, and empathy between physicians and patients. This endowed award is given annually to a physician who embodies that spirit of Ellen Susan. This year's recipient of the award is Dr. Joseph M. Truglio. Dr. Truglio is an associate professor of medicine, pediatrics, and medical education at the Icahn School of Medicine at Mount Sinai. He received his bachelor's and medical degree from Georgetown University in 2003 and 2007, a double Hoya, as they say. He trained in internal medicine and pediatrics at Mount Sinai from 2007 to 2011, where he also served as chief resident. He completed an MPH in global health, during which time he developed clinical and educational partnerships with community health workers in rural Bangladesh, experiences that inform his ongoing work in our local community. From 2011 to 2018, he served as the course co-director for the Art and Science of Medicine course at the Icahn School of Medicine. Since 2018, he has served as the founding program director for the Combined Internal Medicine and Pediatrics Residency here at Mount Sinai, a program that aims to reduce inequalities in marginalized and oppressed populations by training the next leaders in med-peds primary care. Over the last decade, he has developed numerous innovative curricula, including a robust anti-racism curriculum for students, residents, and faculty, and co-authored the first chapter dedicated to racism and bias to be published in a major clinical skills textbook. As associate editor, internal medicine for AMC's MedEd portal, he has helped spearhead the creation of their anti-racism collection and mentorship program. He's also the founder of the Mount Sinai Pediatric Visiting Doctors Program, the first program in the country to provide comprehensive multidisciplinary care in the home to medically fragile children. Finally, it's important to mention that in addition to his numerous accolades, Dr. Truglio has remained dedicated to his patients and his residents. He is a mentor and true friend to all of us medicine and med-peds residents, and he is also an internist and pediatrician in the truest sense. It is my honor to present Dr. Truglio with this award, which I will personally give to you this week. Thank you, everybody, so much for joining us today.
Well, thank you both. That was really special. I really appreciated that, Franz. And yeah, it's a real privilege and an honor to be here today giving this talk. And I do want the talk to be a bit interactive and, a fair bit of discussion. I recognize that Zoom sometimes is not the best format for that, but sometimes it can be. So I think as we go through the content and we talk about our experiences and reflect together, I encourage you to use the chat freely. I have it open on my screen, probably occasionally blocking my slides from my own view, but it's there. And I hope to sort of see your thoughts and reflections. And there'll be opportunities as well to unmute and participate and share, because I think we all come to this and together have everything we need to move this content forward. And to work together in improving, what our institution is, what our profession is. So with that, we'll get started. I have no conflicts of interest. By the end of this session, I'd like us all to be able to describe the ways by which settler colonialism drives health inequities and be able to identify opportunities within our own spheres of influence to decolonize graduate medical education. I like to start with some acknowledgements, and I could probably have a whole talk full of slides of acknowledgements of folks who have influenced me and helped me over the years. A lot of them are on the call today. But I do like to point out a few folks right at the start. because I think it's critical to recognize the history and sort of how we get where we are. And I think if you look at this slide, some of you probably know a lot of these folks. I want to recognize the students in particular, especially students of color, particularly Black women, who over 10 years ago were brave enough to reach out to myself, other faculty at the school, and point out that despite our intentions, a lot of the content we were teaching, the methods, the educational and evaluation methods we were using, were perpetuating racist ideologies and practices. And I know for me, I'm a better doctor, better human for having had those folks as my students. I want to point out the patients who are on here who have been involved in our program, some of whom have lost children and carry on every day and show up to improve the health of their communities. And I want to point out some of the women who have had to make tough choices between continuing in the profession they dedicated their lives to and practicing in environments that were racist or sexist. And I think these folks have really inspired me to sort of think every day and have a lot of self-reflection about the way I teach, the way I see patients, and the way I work with other individuals. So I want to start with a story that was probably about 7 or 8 years ago when I was out visiting a patient just a few blocks north of the hospital. Had a student with me we were seeing who was the grandfather in this family, taken care of by his wife. And we were seeing the older gentleman in his home, and grandma got a call, went back into the room, and it was her daughter calling about their granddaughter who had just been at our peds practice at Sinai. So for the med peds folks on the call, this is a very med peds experience where you're there for one person, but you got the whole family somehow involved. And they're in the other room on speakerphone. I don't know if they knew I could hear them. And she was describing an experience where she brought the granddaughter to our pediatric practice with typical flu symptoms and gone on for 3 or 4 days, was doing okay. She was a little worried because the fever wasn't going away, but she said that, she asked about flu. She knew there was a treatment available. And she said, well, they told me that it'd been too long. So we couldn't, it wasn't worth testing because we couldn't treat, which is, medically accurate. And then she said to the grandma of the family, but, I sort of like my doctor, but, they want to kill all the Black babies anyway. So I left and I'm not sure what to do now with my kid. And, I was sitting there in the other room and sort of overheard this. And then the grandma comes back in and starts asking us questions about the flu and management and what we think about this and that, sort of as an aside. I don't think she knew we had heard the whole conversation, but it really stuck with me because it spoke to the real lived experience of a lot of our patients and their families. And it didn't really matter much, for that mom, the intent of the docs who I work with and I know and guaranteed showed up that day to take amazing care of kids, and they do it all day, every day. But the impact of the way medicine is structured and lives within our society was such that the impact on this family was that's how they walked out of that individual encounter. And this is the context within which those experiences occur. She didn't say that they wanted to kill all the poor babies, right? And these data are repeated over and over again, and it doesn't really matter which metrics you put in, which outcomes you're looking at, but these data show that in America, a Black woman with a graduate degree is more likely to die in childbirth than a white woman with less than an 8th grade education. And when I look at these data, it always reminds me of that sort of quality improvement quote that systems are perfectly designed to get the outcomes that they give. And then there's another quote that I always remember, which is, you can't fix what's not broken. So we really need to sort of pause and look at these sorts of data and look at the outcomes that our patients are experiencing, our communities are experiencing, and think about what drastic changes we need to make within our profession. Because everyone on this call, went to med school and dedicated their lives, right, to do better than this. And I want to share an experience that, I think we often look at data where doctors were supposed to, but our individual patients in our communities have been sort of telling us this for a long time, and we don't need charts and data to understand it. This is the experience of the sister of one of our residents giving birth in our hospital. She has an advanced degree from an Ivy League institution and is the associate dean at Columbia. And this is what she wrote in an article about her experience a few years ago. My son, who's pictured here, was born at 29 weeks, weighing 2 pounds, 14 ounces. For the last year, I have carried with me the belief that I failed him. I convinced myself that the safest place for my Black son was in my Black womb. To threaten his life meant that mine would also have to be threatened. And I just knew I had played enough in the sandbox of white supremacy and patriarchy to at least protect him for 9 months. But racism has a way of intimately reminding me of my inadequacies of fighting such an intricate system. When reading through my medical chart, a nurse felt emboldened enough to write in my record, my permanent record, that I felt that doctors should, quote, go above and beyond to care for me. She wrote it in such a way as to make it seem like I was being unreasonable, as if they weren't mandated to do all they could to ease my pain and keep me and my baby alive, as if my request did not align with their mission statement. The mission of the Mount Sinai Health System is to provide compassionate patient care with seamless coordination and to advance medicine through unrivaled education, research, and outreach in the many diverse communities that we serve. I encourage you to Google this article and read the whole thing because she shares a lot of experiences before, during, and after the birth of her child and the different experiences that she had with her second child, where she sought out an all-Black female OB group who sort of were able to understand her and trust her and her experiences with her own body. And that experience that she had as an individual, the difference between being cared for by someone who's aligned with your experiences, who trusts you as an individual, is borne out in the literature. This is a very disturbing article. And the way it was described initially was that the positive impact of diversity in medicine, that when you have a Black pediatrician taking care of Black babies in the nursery, they're 3 times less likely to die. But the other way of looking at it is that when I walk into the nursery to take care of Black babies, that perhaps those babies are 3 times more likely to die than if they were cared for by a Black pediatrician. And it raises a lot of questions. It makes us not fall into the temptation of looking at big inequities data and pointing outside of our own spheres of influence, that perhaps this is to do predominantly with access to care due to state and national policies, or poverty, or structural and environmental forces that are outside of our control and our responsibility. And it points and it shifts a lot of the responsibility squarely onto our shoulders within our profession. But that also means that it's within our sphere of influence to change. Last week, I was talking with the dad of a patient who we recently started seeing, and he was described to me. I got the sort of heads up call from the referring team that the dad could be a little bit aggressive, which is always a bit of a red flag when I know it's a Black family, in the way that that team is interpreting the family's behavior. And during the call, he said something to me. He said, I always knew about racism with the police and the jails around our neighborhood, but I thought and I really hoped that medicine would be different. And after only 4 years of taking care of a boy with complex medical conditions, he found that that just wasn't true, that these experiences are embedded and entrenched within our profession. And despite having gone to 3 different hospitals within a city that has some of the best hospitals in the world, this was his sort of ubiquitous experience with our profession. So I think it's important for us to take a step back and think sort of historically about our profession's history with race, racism, and settler colonialism. I think these days most folks know these 3 women. I prefer this photo over the one of the statue of Marion Sims that used to be outside our hospital. I was very glad was removed several years ago. This is a poster remembering Anarcha, Lucy, and Betsy, who were 3 of the enslaved Black women that Marion Sims developed and perfected the surgical technique for vaginovesicular fistula repair without using anesthesia. Hundreds of surgeries on these 3 women without anesthesia, even though it was available at the time. And this was done with a purported justification that Black bodies were different, that they didn't feel pain in the same way that white bodies did. And this doesn't stand in isolation, and it does have an impact on us today. You can draw a straight line from early beliefs around biological differences between the races to the way we take care of patients today. I think most folks have seen this first article around racial bias in pain assessment and treatment recommendations. It looked at physicians in training in a variety of levels from med school through residency. And this was published 2015, not long ago. And a significant percentage of individuals in the study believed in biological differences that impacted the way we look at pain for women. The way that Lenara experienced her birthing at our hospital and the lack of understanding of her pain sits within the historical context of Marion Sims and clinicians today, literally believing differences in skin thickness and sensitivity of nerve endings. And it's not just beliefs, it's actual practice when they've looked at how we in pediatrics manage children presenting with diagnosed appendicitis. So a kid with appendicitis in the emergency room, white children are more likely to receive opioid medication and Black children are more likely to receive NSAIDs. And all those kids are going to the OR for surgery. So it impacts the way we think about patients, it impacts the way we manage them. And I think we often, at least at Sinai, I know we spend a lot of time thinking about pain management in this context, but it doesn't stand in isolation. It's not a single event. It sits within a broad context of medicine, of racism being codified into medicine in a contemporary way as it's codified into law. And it's important to think about our profession's history and also where we are today. So if we look at this timeline that shows the interdependence of what's happening politically, economically in the United States from early settler colonialism and starting here with transatlantic slave trade, medicine did a huge part in defining, creating race as a concept. And in early American scientific racism, trying to find differences between the races to justify the exploitation that was happening legally. And over time, this evolved where early American scientific racism sought out those differences. In the early 20th century, there was a paradigm shift where those differences became assumed. And if you look at articles, even today, even in journals like the New England Journal, where they will have an article on, anti-racism, in that same issue, they will have articles that use race and don't define how it's collected, don't define how it's interpreted, and posit differences in outcomes without any interpretation into why those outcomes might be different. So there was a paradigm shift where today we approach research oftentimes as if there are assumed differences between the races and that this can be perhaps a proxy for genetics. The first FDA approved medication with race as a qualifier to use it was approved within the last 20 years. So as a profession, we are sort of not moving further away from this, we're moving further in to scientific racism, but it's becoming more obscure and a little bit harder to isolate and attack. And this sits within the broader context, historically and contemporarily, of colonialism. And I show this slide, we could have a whole talk just on sort of breaking this down. There's some wonderful books published by Dr. Maria and Patel on the topic, and they've given some wonderful talks, I think one recently at Sinai. And, but I show it here just to sort of orient us and point out a few things. I know the title of the talk was Decolonizing Graduate Medical Education. I think it's important to describe sort of what we mean by that. And I think if you walk away with one thing to remember from this talk is that colonialism is not a historical event. It's an active contemporary process that continues to shift power, that continues to hoard resources, to take and hold land and resources and value away from Indigenous individuals and away from Black bodies. And medicine's role in this has been to justify that early by creating racial hierarchies. And it sits within these frameworks of supremacy. It could be white, cis male, human supremacy, and capitalism. And these two concepts are contemporary, and they support each other, and they result in and perpetuate oppression and use and theft of resources that result in individual and generational trauma and the suffering and death of individuals and communities. And while it can be very overwhelming to look at this slide and think, well, what am I going to do about it? Showing up to teach a course at a med school, or showing up, as a new chief resident, or taking care of a patient in a community health center. I think one of the skills here is to think about where within this framework are our spheres of influence and where are the levers that we can pull and change, but we can't find them if we don't know what we're looking for. So I want to take a bit of a step back and think first about our own experiences, because of the folks on this call, there's a lot of lived experiences within graduate medical education. And I want us to pause and just think, and here's where we can put it in the chat, or you can unmute and talk. But I want us to reflect on, in what ways does graduate medical education both rely on and also perpetuate the colonialism that was depicted in the last slide and the one before it? So just have a moment to reflect on that question, and then either unmute and talk if you're brave and in a place where you can do so, or feel free to put it into the chat to everyone or just to me, and I can read it out anonymously. So Dr. Du, I'm not sure if this was from this question.
No,
but-
there was a comment I made previously when you were talking about other things.
Yeah, no, this was, it's a great reference to look at the and the uncovering and the anniversary of the syphilis study that was referenced earlier. So I'll definitely leave that in the chat for folks to look at. I think while you reflect, consider these questions. How in graduate medical education do we assign value to individuals, to institutions, to programs? How do we reinforce hierarchy? How do we hoard power? In what ways do we do this? So there's some comments coming up that I'll read off. So one person pointed out that a good percentage of our leadership, deans, chairs, GME, DIO, are all white men. I actually referenced this when we did a critique of our program and we talked about our anti-racist recruitment techniques. We had our first recruitment meeting, and we were all very proud that we had community members there. We had patients who had interviewed applicants, and then we're sitting at the head of the table, and it's me, Dr. Thomas, and Dr. Foreman, all really dedicated to this work. But three white men just sitting at the front of the table in the seats of power, acting like we're having, a conversation with everyone and that everyone's voices are being heard. So that's hierarchy. Someone else says, I don't remember, our patients mainly being Medicaid fits this context. So absolutely, the segregated care system in which we practice and take care of patients, and in which our residents train and learn, you could think about the flow of knowledge that occurs from Black communities to white communities through the training of clinicians in segregated care systems, the preponderance of whom move on to care for predominantly white individuals. So that is another example of an active process of settler colonialism in which we participate. Metrics that look at percent of US grads, placing a value system in medical education about receipt of care that does not take into account normative cultural differences. Modern colonialism can be seen in how connections and nepotism continue to play such a large role in admissions and promotions at all levels of GME, including medical school, residency, fellowship, and so on. So I think we've all experienced this, right? You do not need this talk to see this. And once you see something, you can't unsee it. And I'm learning from reading a lot of these comments, and I hope that we're all sort of getting different angles. We all have different positions in this. And I think having these sorts of conversations is one of the first steps to make the invisible visible. And with that in mind, I want to actually, if we look at that one branch of settler colonialism, there was a few references to supremacy. And those are forms of culture. And I want to just think briefly about culture. What sorts of, not any particular form of culture, but what are some things that come in mind when you hear the word culture, just generally speaking? For me, it's food. That's just my background. But what things come into your mind when you hear the word culture? And you can unmute or you can throw it in the chat. Yes, food, dress, values, music, language. What else? Religion. What else? Norms, values, belief systems. Yeah, so I mean, it's a broad word. Family structures, holidays. You know, I mean, these are powerful things. These are the things of life, right? Everything from family and religion to food and music. I encourage you to pause for a minute and think about a time when you went away, like far away. So there might be some, graduating residents going on to fellowship, people who have maybe done international travel recently, now that we can with, COVID. Think about a time you went somewhere else and you felt what they would call a culture shock, right? You're in a new environment, things are new to you, there are things you're not familiar with. But then think about when you came back home to your apartment or to your house or to your family, and you knew you were home, right? Maybe it was the way it smelled, maybe it was the way it felt in your feet, right? But most likely there were things there that when you live there every day, when you're rushing to get out of the house to go to the hospital, that you don't notice, but yet they very much inform your body's recognition that it's home and that it's safe. And I think that speaks to one thing that makes culture so powerful is it's ubiquitous and it's predominantly invisible. And we have a fishbowl here because it's sort of like how fish don't know they're wet, right? The longer you swim in something, the less visible it becomes. And a big part of anti-racist work, a big part of decolonizing any system or structure is working to make that is invisible visible. And one thing that we want to make visible within work around decolonizing medicine is white supremacy culture. We were talking about culture in general, but this is a particular form of culture that supports and perpetuates settler colonialism. So let's just walk through some definitions, what we mean. So what we don't mean here is white nationalism, extremism. We mean global worldviews that shift power and privilege towards folks who are called white. So starting with the classic definition of racism by Dr. Jones is a system of structuring opportunity and assigning value based on the socio-political interpretation of how one looks. Racist policies and practices provide that structure. Any policy or practice that, regardless of intent, in a shift in power, privilege, opportunities towards those called white. Just like when I showed up as a new course director, it was not my intent to shift power, privilege, and opportunity towards my white students, but I did in the way I was teaching. Racist policies and practices are supported by hierarchy, values, beliefs, and norms of a predominantly white culture. And those hierarchies, values, beliefs, and norms are what we call white supremacy culture. And they're operating all around us all the time. So we can either disrupt them through intentional actions or perpetuate them through the status quo. So when we show up to round in the hospital, when we show up to a meeting, when we're at a talk like this, doesn't matter what the topic is. You don't have to be, having a patient in front of you who's experiencing racism or giving a talk on race or racial inequities for these systems to be active. They're active all the time, all around us, and part of our job is to improve our recognition of them. So this is one way to do it, is to sort of just spend some time getting to know them and reflecting on them. So here's a few examples. If you're not on your phone and you can do the QR code scan thingy, you can scan this QR code. It brings you to a PDF that was put together by a colleague of ours, Tema Okun, out of Duke, who we've done a lot of work with over the years, sort of describing and fleshing these out. They're not all encompassing, but they are just a few examples. And I think you'll recognize all of them, right? Because they're sort of the way things are in our society. And they're very powerful and deeply hierarchical institutions like medicine in general and academic medicine in particular. And they're things like either or thinking, right? Patients are either taking their medicine or they're not, right? They're either adherent or they're not. There's not a lot of room in the way we think to recognize that a patient can both be deeply invested in their own health, but also either not able or not fully on board with doing exactly what we say exactly when we say it, right? The right to comfort. Generally in society, in our hospitals, there's a sense that white folks, particularly white men, just have the right to walk around comfortable all the time. And we are anxious to bring things up or mention something because we don't want to then be viewed as the person who makes other people uncomfortable. So even once recognized, these systems support each other because we might become defensive or we may want the data, right? We worship the written word. I could have shown you just Lenara's story, but I had to show you the data so that you understood it wasn't just one individual who had a bad experience one day, because we value things that are written down just the same way that settler colonists valued written treaties over the spoken word of the indigenous communities that supported thousands of years of governance and trade on a continent. And we value those things today, which is why we've got to publish, which is why we have to bring the data. And even, we always joke around, even when we do this sort of work, we have to study it, we have to publish on it, we have to write it down. So there is an exercise, I think for the interest of time, we won't do now, but I encourage you to make it part of your daily practice where you look at these and you think about which ones of these do I identify with? Which ones do I perpetuate day to day? One of my good friends and colleagues who's also a resident here was doing a workshop with me on this and mentioned that the worship of the written word and it was something that she felt she perpetuated because she was often given feedback that, oh, you are, and perfectionism. She was given feedback, oh, you're great with patients, you're a great communicator. And she always took that as less than, that if I were smarter, they would say how smart I was. and that she sort of perpetuated that on herself and those around her, even as a Black woman operating in this system. Someone put in the chat, my daughter lived in Ramallah and attended Birzeit University. For one semester of her junior year at University of Edinburgh, she sent frequent emails describing settler experience there. Very interesting. Do you want to expand a little bit on that? It's okay if you just want to use that chat, or if you're not able to speak. Okay.
Yeah, I can.
Oh,
I can
sorry,
speak.
go ahead. Yeah.
I can speak to that a little bit. Yeah, I mean, she studied human geography and Middle Eastern history and culture and Arabic at University of Edinburgh, and went and spent a semester at Birzeit in Ramallah. And basically, you know, she would describe invasions into Ramallah, friends getting shot, markets being destroyed. You know, I mean, this was really gross colonialism. You know, people being arrested, people, you know, I mean, it was just what if you know, looked at any of the, you know, like Haaretz or any of those things, you know, you could find out about. But I think also, you know, I trained at Harlem Hospital and I left LIJ after a year of internship. It was, at the time, it was a pretty unfriendly place to women. And being at Harlem was a really interesting experience because it, you know, it forces, I think, me as a white person to confront internalized racism, to think about how racism works, how it's internalized probably in everyone to, you know, in different ways. And there were things that happened just automatically, like every pneumonia was admitted because this was the rule of Jerry Thompson, the chairman of medicine. You didn't know if any of the people with pneumonia would be able to come back and be rechecked. So they were admitted until they were treated, you know, completely. And there were also, you know, people who came in who lived in basements. There were, you know, and treated in the asthma room. I mean, it just went on and on and on that you had to take into account where people come from. And I was really struck by your first example of, you know, the child that wasn't treated because it took too long for the grandma to bring the child in. I mean, that is something that I think would never have happened at Harlem Hospital. Just, you know, because how we were trained.
Yeah, thank you for describing that. And I think depending on, you know, if we get to it or not, that concept of sort of structural competency and structural humility and thinking about the broader context in which our patients live and which we live and our relationship to them, I think is so critical. So I appreciate that reflection. So now that we have that background, I want to shift a little bit to our program's experience and, you know, ways that we've had some success, places that we've struggled, and really trying to grapple with this concept. And very early on, we made a decision, and Dr. Thomas was involved in this, you know, to really focus on concepts of power within our program. We had early meetings with community leaders. We had power analyses of our practice with our local community, with Mount Sinai, with the real expressed aim of shifting power in residency recruitment training away solely from academic medical centers and towards the patients and communities that participate in the training of these residents. Because one of the concepts within white supremacy culture is that power is limited, so you hoard it. And it's almost like folks don't want you to realize that through sharing power, you actually duplicate it, right? There's more when it's shared and when you're not just inclusive, but also bringing people in order to change structures. And how can you do that? So this has been, you could have more than 4. I picked 4 because it makes a nice circle. But these are a few sort of domains within graduate medical education and a few sort of self-reflection questions. This work always starts with reflection on self and then reflection of yourself in relationship to others. But we can think about these 4 domains around program structure, around relationships, around curriculum, and around faculty, and ask some real critical questions about ourselves. And we'll go through a few examples. So let's start off with the bottom half, program structure, and also relationships. I think these are intimately related with each other. So we all have our programs all have mission statements, right? Our hospital has a mission statement. Lenara knew it and quoted it in her article. But who decides that mission, right? Who has a seat at that table and who's actually accountable, whether our programs, our training programs or institutions achieve that mission? And who gets to decide the design of that program? Everything flows from that. Your recruitment goals, the metrics, do they flow from that mission that was developed in real power sharing with real relationship via anti-racist methods? And then always thinking, well, which voices are not represented in program power structure? Because you never have everybody. And it's really important to think critically about who is being excluded. And then start to think about those relationships, the power differentials. Are they explicitly recognized? And are the racist ecosystems within which these relationships exist recognized and challenged? So if we look at our Med-Peds program, we can look at a few examples of our structure around mission, recruitment, curriculum, evaluation. When we started our mission statement and thought about what our program would be, we had a series of meetings with community members, with patients, with folks from within the hospital, nurses, social workers, chaplains, faith leaders in the community, the PTA president of one of the schools who was not a patient of ours, but established in the community. And they really came up with 2 broad principles around dedication to racial, social justice and community, and dedication to primary care. Now that was for our program, but it's hard to argue that that same process couldn't be of value in any program. We asked them, when you want to see your primary care doctor, what attributes do you want them to have, right? They didn't talk about AOA. They didn't talk about top 20 med school. They talked about knowledge, but they also talked about communication. They talked about real dedication and understanding to the community. They talked about accessibility, about looking at them. One of them had a great idea of, why don't you give your interns a 6-month trial period and then you can fire them if they don't do well, which I don't know if ACGME would approve, but they had, they were not thinking within the frameworks that we often approach developing programs. So what we developed was a sort of corollary to holistic review process, which is similar, but starts in a different place, because where holistic review starts is with a pre-existing mission of your program or your school or your institution, without ever asking the question of where did that mission come from and who does it serve. So we developed the metrics with the collaboration with our community. We blinded things like AOA, board scores, clerkship grades were de-emphasized, because those things perpetuated structural racism within our society. Sorry, my chat is in the way. And then we, as I mentioned, had recruitment committees that reflected power sharing, right? We realized very early on the committee involved patients, but the patients weren't interviewing applicants. So we started that process, and that made a huge difference in having them involved every step of the way, start to finish. But we recognize, right, that it's hard, for example, to have patients who can't take that time to be involved, patients who have limited English proficiency or speak other languages, patients of our practice at Settlement Health who are undocumented and are afraid to be involved in processes like this, as much as we desperately need their input, because the folks with the solutions to the problems are the ones who are there living them. And yet they're the ones, our toughest problems. We talk about segregated care, we talk about Medicaid versus private. What about undocumented, uninsured individuals? And those folks, the ones who have experiences with the hardest problems we're trying to solve, are universally excluded from the conversations around fixing them. And in this case, because they're afraid, and I can't blame them. We did extensive training around our recruitment process. And this is one example slide from one of our talks where we trained our interviewers just about the language we use, right? I think grit is something that I used to say this was a great attribute, right? Wow, this person, they have such grit, like look at their background. Whereas it's more about what we were not saying. It's a coded term for saying that a child, or this is from high school and college admissions processes, survived conditions of white supremacy, anti-Blackness, and capitalism without having to name those systems directly or their correlative effects of young people of color. So instead, in our conversations, we try as much as we can to actually name and contextualize the actual structures and systems that impact our applicants. Moving on to curriculum, I think the mistake around decolonization, around anti-racism, is that we always start off, I used to start off thinking, you have a talk on race or racism, right? And that's your content. Whereas it's really, no matter what you're showing up to teach, no matter what, the way you teach, who is doing the teaching matters. The way you're evaluating your residents matters. There's bias and oppression sort of baked into all of these systems. So we have to think broadly about that, and we have to ask questions about how are these skills developed? Do we have specific competencies that we're trying to meet? Are they included throughout the program and the curriculum? Is it a day-to-day thing? Do you have like a carve out an hour on anti-racist skills and you can tick the box? So one of the curricula that we developed that now all the medicine, all the peds residents get, med peds, it's in the med school, is really trying to deconstruct some of that history that I described earlier on race as a biologic construct. This is ubiquitous in clinical decision tools and guidelines. A lot of folks on this call took national leadership in getting it removed from the EGFR. It's still in bioreference. So again, for our most vulnerable patients who get care in our community health centers, whose labs get run at bioreference, they still correct for race when reporting the EGFR. It's in how we dose transplant medicines. It's a button on the machine when they do pulmonary function tests, right? And machines from South Africa have black, white, and colored as the options. And we don't get that in the report unless Dr. Dewey, you know where to find it. I know we've had this discussion, like I can't even figure out what race they assigned my patient and the impact that might have on their predicted volumes and their likelihood of either, getting workers' comp or getting a transplant, right? So these have real world implications. So we develop competencies that are this is a screenshot from New Innovations, that where we evaluate our residents on their ability to engage in this. And we give them a few options around when you see these racial differences, it's either inaccurate or flawed data, like estimated GFR. It's a conflation of race with geographic ancestry, like sickle cell, that includes parts of Africa, parts of the Middle East, doesn't correlate with our contemporary economic, political understandings of race. Or it's an example of racist policies and practices manifest either as direct impact or through epigenetics. And because it's Sinai, we're going to use a cardiovascular example. We use this tool all the time to estimate someone's risk of atherosclerotic cardiovascular disease. It is no question that Black individuals in the US have a higher burden of death from cardiovascular disease. This is a correct observation. The conclusion that can be assigned to an individual and a tick of a box that then shifts the burden from our structures to the individual and obscures the true drivers of that disease process is the problem. There's data that have been published that show as increased rates of housing segregation occur, your systolic blood pressure goes up. There's data that show the impact of segregated care on access. And there are data that shows that the higher a white clinician scores on the implicit association test, the less likely they are to recommend appropriate intervention for Black individuals who show up with typical ACS symptoms. So these are just three of the many things that actually result in an increased risk of cardiovascular death. So when we engage with patients, we recognize that we try to get a range of their cardiovascular risk. We refine that risk. Just like if you have someone with bad rheumatologic conditions that are undertreated, you know they're going to be at higher risk for cardiovascular disease, you can adjust that tool. You can talk to the patient as well about their pill burden, their family history, and then make a decision. And then most importantly, try to identify and mitigate the actual drivers of that individual's cardiovascular disease. When we presented this workshop and this approach to our program evaluation committee that includes patients, their recommendation was that they were very happy that our residents were learning how to talk about race. To talk about was racism. And they wanted us to go back and teach them and make sure that they knew and they could talk to them about their experiences. And this is something we're not very good at, right? Our residents around the country are not trained. Like when you're a pediatric resident, you're trained to talk about swimming pools, you're trained to talk about firearms, you're not trained to talk about how a Black teen should talk with police or what they should do if they are pulled over. And yet they're more likely to die in that scenario than in many other things that we spend a lot of time talking with our adolescents about. So we've developed these other competencies around structural competency. These we actually were able to just take from this lovely article. We're looking at the capacity for health professionals to recognize or respond to health and illness as the downstream effects of broad social, political, and economic structures. And then lastly, ones around power sharing. So these are just a few examples. I don't want to go through in detail because I want to leave a few minutes for questions and discussion at the end. But that was just the sort of structure, relationships, and curriculum. I think we do need to recognize who's actually doing this teaching, where we place the emphasis, where we value time, and where expectations are set. And we don't really have time to get into this bucket today, but just think within ourselves, within our programs, you know, is the expectation for anti-racism distributed equitably across faculty? There's been a lot of work within this department in particular around that distribution, encouraging folks, right, to engage in this work, paying for people to go to workshops on this content, right? Our white faculty developed on how to mentor trainees of color. These are very basic, granular questions that we could ask of ourselves to sort of round off this last domain for our programs. So lastly, I'll just revisit our objectives, and then we might have some time for questions. I hope that now we can describe the way by which settler colonialism drives health inequities and continues to do so as an active contemporary process, and identify opportunities within our own spheres of influence. Every single person on this call has multiple spheres of influence. What are our opportunities to decolonize graduate medical education from where we sit? So thank you. And I'll actually, I think these get shared later. I have the references from the articles that could be of interest for anybody. I'll stop share because I think then we can have a couple of minutes for questions.
Thank you, Dr. Truglio. Terrific. Yes, we have some time for questions either by the chat or comments.
I just wanted to say that I think, you know, this is a very important Grand Rounds, should be repeated regularly. And it's very, very important for each of us to look at ourselves and see how we've been affected by settler colonialism in this society. And, you know, this has been a discussion in my family since I was quite small, but not everybody has that benefit. And, you know, the things change as the world moves on also. You know, as we see the relative impact of SARS-CoV-2 on poor and underserved and, you know, minority or soon majority communities. And I think, you know, there's every day we can see, you know, how this is affecting our society, especially in New York City.
You see the question, Joe?
Yeah, so thanks, Robin. Question says, in starting the MedPeds program and choosing residents based on these values, what changes in the perception of medicine have you seen in your patient population? It's a good question. I actually can't, I'm not sure I can say and speak for the patient population. What's interesting for our program is a new program. Our continuity practice is at Settlement Health, which is an FQHC in East Harlem that has not had a significant resident presence previously. So I think it's sort of new to them. But we've had a lot of discussions with them around what this all means, like what resident education is. And I think that's been one real substantive change for the patients and community members that have been involved. They sort of know what a med student is, what a resident is, what a fellow is. There's some med school folks on the call, and they developed their medical education program objective around racism and oppression. One step in that process was bringing in, through a bunch of different methods, patients, community members, community-based organizations, and having them give input into developing that objective. And a lot of that process was, if you ask someone, what should a graduating med student be able to do and to know? Well, you need to know, what does it mean to be a graduating med student? Where are they going off to next? So we're all learning from each other in this process, just like I'm learning what's valuable and important and the strengths of our community. They're learning, when you say they're a first-year resident, like, what the heck does that mean? And what should my expectations of them be? And now they get it. A lot of them will come in. They'll come in they'll be like, oh, where's Lily Chu? Is she post-call? Like patients used to not talk that way. And now they do. So I think that there's been that partnership and collaboration that's been really exciting to see.
So it looks like we're coming up on the end of the hour. I wanted to thank Dr. Truglio, tell him how proud the department is of his great work in this area, and also of starting our MedPeds program with a focus on anti-racist care and anti-racist education. And for those on the phone, I should know that when the ACGME came back to accredit our MedPeds program, they were absolutely stunned at our approach to medical education and the MedPed and patient care and the MedPeds program. So really, Joe, you are a national, person of national fame for this, as we all know. So thank you very much for that. I really also want to thank the Skolnick family for all the support that you have given us over the years too. So with that, Joe, thank you. Congratulations on an absolutely terrific talk. Have a good day, everybody.
Thank you.
Enjoy. Have a nice one. Thanks, Joe.
Bye-bye.